On behalf of my co-authors, I would like to thank the Kidney Cancer Association for inviting me to present our abstract, the association of the neutrophil to eosinophil ratio with response to ipilimumab plus nivolumab in metastatic renal cell carcinoma. As we know, neutrophilia is associated with overall worse prognosis in metastatic renal cell carcinoma and is a key component of the IMDC risk prognostic criteria. Retrospective analyses in metastatic melanoma have shown an association with a higher baseline eosinophil count and improved outcomes to immunotherapy. A retrospective analysis of 90 patients with metastatic renal cell carcinoma treated with nivolumab monotherapy showed that a higher baseline eosinophil count was associated with a lower risk of progression. Based on this knowledge, we decided to investigate the association of the baseline neutrophil to eosinophil ratio with response to combination immunotherapy with ipilimumab plus nivolumab. Our hypothesis was that the median neutrophil to eosinophil ratio would be significantly lower among patients with complete response and partial response to ipilimumab plus nivolumab compared to the median neutrophil to eosinophil ratio among patients with a best response of progressive disease. Patients 18 and older with metastatic renal cell carcinoma treated with the combination ipilimumab plus nivolumab up until June of this year at the Vanderbilt Ingram Cancer Center were included in this analysis. Patients without a baseline CBC with differential within 2 weeks of treatment, and patients without at least one post-treatment CT scan to assess for response were excluded. All data were collected and stored in a password-protected REDCap database. The Mann-Whitney test was used for comparison of the median neutrophil to eosinophil ratio and median baseline values for eosinophils, neutrophils, and lymphocytes. Analysis of progression-free survival was performed using the log-rank test and the Mantel-Hensel method, and analysis of the odds ratio for overall response rate was performed using Fisher's exact test. The baseline characteristics of the less than median neutrophil to eosinophil ratio group and the greater than median neutrophil to eosinophil ratio group is shown below, with 20 patients in each group, along with the baseline characteristics of the overall cohort. As you can see, the overall cohort was predominantly male with a median age of 58 and an interquartile range of 52 to 65 years of age. 95% of patients in the less than median neutrophil to eosinophil ratio group had prior nephrectomy, compared to 45% in the greater than median neutrophil to eosinophil ratio group. The BMI of the less than median group was slightly higher at 31 compared to 28. 88% of patients in the overall cohort had clear cell as their primary histology. Notably, 40% of patients in this cohort treated with ipilimumab nivolumab were treated in the salvage setting, having progressed on at least one prior line of therapy, and 10% of patients had received prior immunotherapy. The breakdown between groups by IMDC risk categories is shown below. As you can see, there were numerically more patients with favorable risk disease and numerically fewer patients with poor risk disease in the less than median neutrophil to eosinophil ratio group as compared to the greater than median group. The median baseline neutrophil to eosinophil ratio among patients with partial response was significantly lower at 22.5 versus 51.8 among those with progressive disease, with a p-value of 0.02, meeting our primary endpoint. As shown on the violin plot to the left is the distribution of response in each group. Highlighted in green are patients with partial response, and highlighted in red are those with progressive disease. There were 8 patients with stable disease, with a median baseline neutrophil to eosinophil ratio of 18.9, shown here highlighted in gray. For secondary endpoints, patients were separated into 2 groups by the median neutrophil to eosinophil ratio, with 20 patients in each group. The median progression-free survival for patients with less than or equal to the median neutrophil to eosinophil ratio was significantly longer, at 7.8 months versus 2.6 months for patients with greater than or equal to the median neutrophil to eosinophil ratio, with a hazard ratio of 0.39 and a p-value of 0.02. Shown on the left are the Kaplan-Meier curves for both groups, shown for progression-free survival. The overall response rate was 35% among patients with less than or equal to the median neutrophil to eosinophil ratio, and 15% among patients with greater than the median neutrophil to eosinophil ratio. The odds ratio for partial response was 3.1, with a confidence interval of 0.7 to 12.2. A bar graph of best response is shown on the left. As you can see, the group with greater than or equal to the median neutrophil to eosinophil ratio had only 3 patients with partial response, 2 patients with stable disease, and 15 patients had progressive disease as their best response. In the less than or equal to median neutrophil to eosinophil ratio group, 7 patients had partial response, 6 stable disease, and 7 patients had progressive disease. We decided to perform an exploratory analysis in order to determine if eosinophils or neutrophils contributed more to this difference in median neutrophil to eosinophil ratio. The median baseline absolute eosinophil count among patients with partial response was significantly higher at 0.25 versus 0.09 among those with progressive disease, with a p-value of 0.02. A violin plot of these distributions is shown on the left. There was no significant difference between the median baseline absolute neutrophil count between either group, with those with partial response at 5.03 and those with progressive disease at 4.64. There was no significant difference between the median baseline absolute lymphocyte count among groups either, with those with partial response with a median absolute lymphocyte count of 1.66 versus 1.29 among those with progressive disease. There was no significant difference between the median baseline neutrophil to lymphocyte ratio among patients with partial response at 2.67 versus patients with progressive disease at 3.85. However, as shown in the violin plot on the left, there does appear to be a trend towards improvement with a lower neutrophil to lymphocyte ratio, as has been noted in other studies. In conclusion, the median baseline neutrophil to eosinophil ratio was significantly lower among patients with partial response as compared to those with progressive disease. This effect was largely driven by the baseline eosinophil count, which was significantly higher among patients with partial response compared to those with progressive disease. There was no significant difference between the baseline absolute neutrophil count or the baseline absolute lymphocyte count between groups. When split into 2 groups by the median neutrophil to eosinophil ratio, there was a significant improvement in progression-free survival. In the future, the neutrophil to eosinophil ratio warrants prospective validation to evaluate its role as a candidate predictive biomarker for response to immunotherapy combinations in metastatic renal cell carcinoma. A planned analysis to evaluate the change in the neutrophil to eosinophil ratio over time while on therapy is ongoing. Evaluating the neutrophil to eosinophil ratio with other immunotherapy-based combinations, including VEGF-IO combinations, is also ongoing. Special thanks to all the co-authors who contribute to this ongoing work, and thanks to my fellows at the Vanderbilt University Medical Center for all of their support. And special thanks to all the patients and families who participated in this study.